Okay. Good morning, ladies and gentlemen. Near the lunch, but still go on. Probably to that everybody thinking about that the DORV, that the food of the stomach and the food of the brains, and like a DORV party. But still, we have no stop that this conversation never end because of that DORV is much variety is there. You understand? And also to that the patient by patient is that not uniformly. That try to that strategies, many surgeons is a little bit different. And also I'm that very simple head surgeon. So neonatal surgery and also should wait. And also we can do that next stage and step by step the operation needed. So thinking about that every cases. So sorry about that. And also my presentation today, LVOT after the biventricular repair for DORV for our TGA with PS. And this is the impact of the length between the top of the interventricular septum and the aorta. So, and how long to the left ventricle to aorta? Just not so uniformly to articles. How long to that available to a biventricular repair or not? Nobody knows. So I just thinking about that what data is showed about that. And also TGA, BSD, PS, and multi-surgical strategies. Good surgeons do the Nikaido procedures, and also Chinese good doctors and the double root translocations. And also Japanese good doctors, Dr. Yamagishi, do a half-turned truncal switch operations. But one of that, I show you that the last one is a pulmonary root translocation, very simply and very close to left ventricle to aorta. And the background of this studies, and the patient undergoing the last stage type operation often require a long intraventricular rerouting patches. So probably to adult congenital heart disease, ACHD area, I had that lots of re-operation is this DORV operation, subaortic stenosis. So a big patches, that's a very big problem about that, the calcified, and also very high, very stiff. And open subaortic portion is very difficult situation, like subaortic enlargement technique. It's a very difficult situation. It's a hard purchase. It may be a risk factor of the mortality left ventricular outflow tract obstruction in the neonatal period, even adult congenital areas as well. However, there is no evidence to support this and how long. That is not hypostasis. Objective of this presentation, the purpose of this study was to describe the mid to long-term outcome in a patient who underwent last stage type operation. Just a limited operation is a last stage type operations, and the variety whether the length of the interventricular rerouting patch really affected the outcomes. So this is a very small number of cases, the DORV, BSD, and TGA, and the CCTGAs in the combined belonging in this our studies. Median age is 28 months, and the median body weight is 11.3 kgs. Meaning this one is very important, good LV function, and also good LV and the size, and very small numbers. And the surgery usually do that cardiopulmonary bypass, mid to moderate hypothermia, BSD closure by aortomy and RVtomies as well. Right ventricular outflow tract reconstruction and artificial valve conduit is 18th, homograft is 2, and direct anastomosis with LVOT 7 and without MVOP is 3. Pulmonary valve valvotomy only 12, and direct anastomosis was 1, and muscular resection RVOT in all patients. Without, and early death is a small number, it's 1 death loss, and also late death is 3, LVOT is 2, and ventricular fibrillation is arrhythmia is 1, and LVOT and 4. This is a very remarkable. 4 LVOT patient, 2 died. Rate arrhythmia is 3, and redo operation is 8. Like that, LVOT aneurysm and residual BSD and PVO release and redo LVOT hours. And the risk factors and also analysis, and the TR is more than moderate, and also alive and died, and then died patient is very small numbers, but still and have some arrhythmic problems there. And the length between the IVS and the aortic valve. This is IVS to AV valve length. Probably to recently lots of modalities there, like 3D model, and Dr. Seo and presented yesterday is very quickly to CT, converting to beautify to 3D virtual models. Very, very good, usually to the good modalities there, but very simple to angiography and also echocardiograms, how length of the between summit of the BSD, IVS to aortic valves. So we calculate there. So and also many factors, and I checked to the IVS to and body weight and regulated, and also BSA and the normal AV size. But this one is a very good correlation about the IVS to aortic valve length. So per normal LVDD. This one is very, very simple, and also this one is at a good correlate to a survival or not. So larger LVOT tunnel is risk factor. What the risk factor is that the number is 0.8 IVS aorta length per normal LVDD. This one is that mortality is lowish, and also this one is more than long distance of the aorta to BSD or IVS length is more than 0.8 is that risk factor. And then comparative study is the patient group A and group B, and the long distance is group B, and the short distance is that the group A. So which is different about that? This one is a group A, group B, and estimated LV diameter and the diagnosis and tricuspid regurgitation and the RV-EDB is not much different. And the group A and the group B surgical data, as the group A is a short distance, is a little bit long terms, and cross-clamping time is shorter and the group A's. And also group A is a no death, but a group B is a long distance when is that high mortality is there. So I just checked to that the group A and the group B estimated survivors in this, and the short distance one is that the good result, but the long distance is that high mortalities. And also RVOT and pulmonary obstruction is something, and then some estimated cardiac event-free survival is group A is better. So affected large because of that. What the relation of the RVDD is that the big patch inside the right ventricles is that one of the risks. The limitation is the retrospective study and the normal multivariate analysis direct patient is anastomosis spectrum of the heart. And this one is conclusion is please remember the number is that very simple. In the summit of the left interventricular septum to the aorta per normal LVDD 0.8. And then do that Japanese good surgical surgeons and half-turned truncal switch operation, even big distance one. So Dr. Professor Yamagishi presented this slide to me, half-turned truncal switch operation. Probably you know about that. But this one is cutted to aorta and also infundibulous septum as well. Then aorta and pulmonary artery just turn off. But this one probably very complicated for me because of that aorta and keeping, and also pulmonary valves keeping as well. Then turned, because of that I said to that very simple head operations, surgeons, but very simple and pulmonary root translocation, excise the pulmonary annulus, then put in just a patch and see how go, like that. So what's happened to this pulmonary root translocation is operation. And the purpose of this one is the long distance of the left ventricle to aorta. That patient do that, this operation, kind of that. And pulmonary root excised from the heart, and then to a fibrous ring excised as well. But some muscle subaortic portion and the subpulmonary portion is excised, then put in a patch. So a preoperative echocardiogram patient is at the long distance, 28 millimeters from the interventricular septum to aorta. Then after the excised and then close the BSDs, then 21 millimeters. So just to excise the pulmonary fibrous ring, excise that, and then put in a patch. Then little bit shifted to posteriorly to aorta. Just a very useful one, and the long distance of the left ventricle to aorta, one of the option to the good surgical outcome. Very simple operation, but effective to avoiding LVOTO. Please remember to this number, and also pulmonary root translocation down to this one. Probably our data is previously before pulmonary root translocation, some patient died, but saved a life. I think that. Thank you very much for your attention.